Joining us for today's announcement are Michelle Thompson, Minister for the Department of Health and Wellness, and Dr. Christy Bussey, Medical Executive Director for Central Zone at Nova Scotia Health. Before we begin, I'd like to also introduce Karen Oldfield, President and CEO of Nova Scotia Health, who's going to join us for some introductions first.
Everyone. Get a slightly different role today. Welcome. And I have the great pleasure today of introducing quite a cast of clinicians across Nova Scotia who I think are pretty excited about the announcement today. And so I'd like to begin by welcoming Dr. Krista Jangard, who's the CEO of the IWK, Dr. Leisha Hawker, President of Doctors Nova Scotia, Mr. Brian Sandegar, who's the General Manager of Oracle Cerner Canada, and a number of other healthcare professionals, including Dr. Stephen Lowney, neurosurgeon in the Central Zone, Dr. Matthew Clark, who's been instrumental in this journey, Dr. Kathy Connell, family medicine and obstetrics at the IWK, Amanda Tinning, nurse practitioner with the Home Transitional Heart Failure Clinic, Dr. Anne Chasson, hospitalist from the Western Zone, Dr. Luke Richardson, emergency physician, Western Zone, Dr. Gail Tomlin-Murphy, Nova Scotia Health, Dr. Nicole Boutlier, VP Medicine at Nova Scotia Health, and our two prime clinicians of the hour, Dr. Christy Bussey and Michelle Thompson, RN and Minister of Health and Wellness. Good morning, everybody, and over to the Minister.
Thank you. It's not very often I'm in a room with this many happy doctors, I have to tell you. I've never actually seen it before, so it's nice. I'd like to acknowledge and thank Dr. Christy Bussey and Josh Lee first for leading the technical briefing. It's really not an easy task to explain one patient, one record to anyone who doesn't work in healthcare and to understand not only the opportunities but some of the current challenges that we're facing. So thank you. You did a really great job. Since coming to office 16 months ago, we've announced significant historic investments to improve healthcare in Nova Scotia. We're providing more ways and more places to receive primary care, virtual care, mobile clinics, urgent treatment centres, new funding for collaborative family practices, expanding the role of pharmacies, and we've stepped up efforts to recruit, retain, and train more healthcare workers, including last Friday's announcement of a new medical school at Cape Breton University in partnership with Dell School of Medicine. In mid-December, we announced major capital expansions to provide more acute, long-term, and transition to community beds, more ORs, 2 larger EDs to address growing demand within HRM. Earlier this month, we accelerated efforts to improve emergency services across the province, and we're working with our partners leading the country in reducing unnecessary paperwork for physicians. Today, we are taking another important step in our efforts to ease the administrative burden on Nova Scotia's healthcare professionals, this time investing in one patient, one record. The wiring needed to help our hospitals and healthcare system operate more efficiently for the benefit of both patients and providers. For years, doctors and nurses and allied healthcare professionals have been telling government that the current models for collecting, recording, and sharing information are robbing them of valuable time they could be spending with their patients. And for years, patients have complained that they've had to go over their medical history, their list of medications with multiple care providers on multiple occasions, often in the same hospital on the same day. They're both right. Regrettably, we're using 20th century methods, the fax machine, the phone, paper charting, to record and share patient information. And many of the IT systems that are in use are either old and failing or incapable of communicating with one another in a way that provides healthcare workers with an easy access to the up-to-date, real-time information they need to more efficiently, effectively, and safely care for their patients. That's not in the best interest of patients. It's not in the best interest of our providers. And now, it's how a modern, well-run health care system should function in the 21st century. I've said on many occasions we're using every tool in our toolbox to provide Nova Scotians with better and faster care. And One Patient, One Record, or OPOR, is one of the most important tools we have for improving patient care and outcomes. In fact, it is exactly the kind of data-driven, outcome-focused initiative the federal government has suggested it is willing to invest. Specifically, OPOR will help speed access to care at our emergency departments, reduce costly and duplicate testing, prevent the chance of human error, provide clinical staff with standardized workflows, forms, and data for assessing and treating patients, recruit and retain vital healthcare workers. Additionally, it will complement other initiatives currently underway to reduce wait times for surgeries, including the new centralized surgical booking system, which will be launched this spring, and C3, the Central Coordination Center, which, when fully operational, will identify bed capacity across the province and speed hospital admissions, the first province-wide system of its kind in the country. I fully expect that some will question why we're investing in technology when there are so many other needs within the healthcare sector. And the answer is simple. It's because OPOR is an investment in improved care. It will help us make the most of the resources we have, and at a time when we have global shortage of healthcare professionals, not enough beds to meet demand, and our healthcare workers are stretched to the limit, investing in new technology to relieve the burden on frontline staff and to achieve better patient outcomes has never been more vital. As the Canadian Association of Emergency Physicians said in a recent letter to the federal health minister and to every provincial health minister and premier in this country, governments must take bold and precise action to address the way hospitals and health systems are managed. OPOR is the latest example of how Nova Scotia is answering their call and doing just what the doctors have ordered. OPOR is an essential piece of health system transformation.
Do you have a sense of why it's taken this long to get to this point?
It's only taken me 16 months to get to this point.
Be that as it may, you're not the first minister who's talked about this idea. So, as you've become acquainted with this process, why is it only now that this is finally becoming a reality?
I think it's a big project. I think it's got to reach across our province. It is a significant investment. I can't really answer that. I don't know. But for me, as a former clinician, it's absolutely essential piece of infrastructure. I've worked with the systems that we're talking about that are dated and difficult to manage, and I've seen it in action. I was able to see this system in Vancouver, and it was absolutely amazing. So I'm really proud of this investment, that we've made the decision, that we've made the investment, and that we have the support of the full government in order to push this through. So I'm very, very proud of this accomplishment today.
Just wondering, you made the comment about initiatives that the feds like. Has there been any indication from Ottawa that they may kick in and help pay for this?
We're hopeful. This is one of those things that we feel is a good example of how we can talk to our federal partners about, what are the investments that we can share together, and this will give us that data-driven outcome decision making that they've asked us to show.
Have you made a formal ask to Ottawa for help?
There'll be ongoing asks, yeah.
What about getting private clinics and private practices using the system? There's been some trouble in the past getting doctors to switch to electronic record keeping.
So I think Dr. Bussey had said earlier, the OPOR currently is really focused on acute care, right? In our acute care systems, our sickest people, right? The people that are admitted to hospital. And Dr. Jangard and I were just speaking prior to what this allows us to do. We had a great example. So if we have a sick child, IWK physicians in that moment, as soon as they're engaged, can see the care of that child in their community hospital or in their regional hospital, and it will all the information will be pulled forward if the life flight is involved, if EHS is involved, constantly allowing that specialist clinician to see that patient, that child, all the way through their journey until they reach that specialist care. So I think there is opportunity. I think primary care providers in the community will have an opportunity they haven't had before to see their patients as they're in hospital. Certainly if they work as a hospitalist, they'll have opportunity to input information in it as well. I think it's only going to grow, but there will be interface for sure, but it's what it does for our acute care system, connecting our rural, regional, and tertiary and quaternary care is really important.
You talked a little bit about your experience seeing this in Vancouver. What stood out for you with the benefit of having the background as a healthcare practitioner? What stood out for you about that system?
So when I went to FPT, the federal provincial meeting in Vancouver, we had an opportunity to tour, the deputy minister and I. And so I was able to go to Vancouver General in a 50-bed intensive care unit, day 2. They had implemented it the day before. I had an intensivist internal medicine physician meet me at the door, so pleased with the view. He said he felt like he was a pilot in a cockpit. He could see so much of the patient. He could trend the patient. He was able to have a different conversation with the nursing staff as a result of him being able to see the full record. He didn't need to be right there. He could see it remotely. The other thing is that it was so peaceful in the unit. I remember years ago when we implemented the first medical record, it was not peaceful. It was very stressful. But that at the elbow support, that support that we had, or that the folks had, not only people from the company, but clinical support as well, it was just peaceful in the unit. I think you mentioned that before. It was just, they loved it. And the technology, but it hadn't disrupted the unit. And in a 50-bed intensive care unit in Vancouver, I felt like that was very telling in terms of, one, how it was implemented, and 2, the benefit to clinicians.
Minister, are we losing an opportunity by not including family physicians in this right now? I know you said that it's important for the most acute cases, but someone who's lucky enough to have a family doctor is regularly going to their family doctor and then has an emergency and ends up in hospital. I guess the hospital won't have any of their records from the family doctor then, right?
Right, but it's head and shoulders above where we are now. So we're going to work with those family physicians. When people present to an emergency room or in a regional hospital, if there's any type of consult that has to happen in Halifax, those docs can reach right in and see in real time. Physicians can be in their offices and see in real time what's happening in hospitals. So in fact, it's an enabler. It allows them to see what's happening and to have different conversations versus asynchronous conversation. So there is opportunity. We have medical records, in community, and over time we hope that there'll be interface. But this is really around that communication, improving redundancy, making sure that there's a different degree of safety in hospital in those highest risk settings. It's it's very exciting. It's a very exciting day for clinicians.
Can you talk a little bit about the process that you're going to use as you move towards giving patients access to this?
Can you talk about that?
Yep. So the process itself, so some of that remains to be seen. So we will certainly be looking to our vendor colleagues on experiences they would have had in other implementations, lessons learned, things that work well, things that didn't work so well. And we will use that information to help us in that design and build phase in the first 24 months to actually determine more about what that looks like. So although we might know from how this has gone elsewhere, we may anticipate what it might look like, we're not quite sure yet exactly what that'll be in Nova Scotia, because we have to engage with patients and families and community partners to help inform that decision making. And we haven't been able to yet. Without the signed contract and ready to jump in the first 24 months, we've not been able to move forward with that yet.
But can you talk a little bit, I guess, about what will go into that, what you're looking to determine? Because I can imagine some people will hear that this thing is finally coming along, and they're going to say, oh, finally I'm going to get access to my stuff. Mm-hmm. But that's not quite how it's going to work. There's this determination before that happens. So can you talk a little bit about practically what are some of the considerations that go into determining what they will finally get access to?
Yeah, so I think there's two things, Minister Thompson. Like, I'm focusing on OPOR only. There's other sorts of things that are certainly very intentionally being worked on as well with respect to digital access to healthcare records. Mm-hmm. So for OPOR, we are looking at that acute care information being able to be accessed into a patient portal or into a portal. whether or not there's other work that happens with taking information out of other electronic medical systems that are not in the hospital system and pulling that together into one platform, work around that is ongoing as well. So I'm really just able to comment on the OPOR portion of that.
Okay,
Yep.
but just so I'm clear, are lab results part of OPOR?
Yes.
So
Lab
can you talk about lab results?
Yep, so lab results, absolutely. Diagnostic imaging, x-rays, ultrasounds, CAT scans, reports. So if there's a consultant, like say you're sent to see an internal medicine consultant, you're sent to see Dr. Lowney as a neurosurgeon, that information will be captured in OPOR and shareable and accessible by the patient as well. So very different way of providing care and a very different access to health information than what we're currently used to experiencing today.
So nurse practitioners and virtual care doctors should all have that access to that information?
I would expect, yes, that they would, yeah.
Minister, in your mind, what are the practical implications for the system of having this in place once it's fully rolled out across all of the zones?
Well, I think, you know, we've kind of highlighted those things, the efficiencies and the safety, right? So our ability to see, and you know, a number of different things, that real-time support, as there is a chain if you require care in a different facility, the ability for us to see whether tests are done, whether there's redundancies. There's so many things. I think we could talk for a long time about the possibilities. And then, you know, making sure that as people's condition changes, whether it improves or deteriorates, we can identify through the interface with C3 where the most appropriate place for them to receive care is. We can see the capability of that. So for us, it's a web of communication that will exist underneath the care of the patient that will support all clinicians in making better decisions for the patient in a timely fashion.
Minister Thompson, just a quick question. Do you have any sense as to what the operating costs might be on an annual basis for the province?
Yeah, we'll do that through the regular budgeting year, because I think over time it would fluctuate. Certainly, there would be more, you know, resources required in the earlier days versus maintenance and things like that. So annually over the budgetary process, we will look at those. So that's always under consideration. So annually, we'll reconsider that.
That's above and beyond the contract with Oracle, right?
Yes.
Minister, obviously this is a phased plan. For medical professionals, what will be the first thing that they notice as this comes to action?
You can talk about that.
Yeah, so I think it's accessibility will be the biggest thing. And we saw that when we were in Vancouver as well, experiencing their go live. So for clinicians right now, having to log on to different systems to get snippets of information to try and synthesize, you know, what do I need to do to care for this patient? Do I have a full picture of the patient right now in front of me and the issues I need to address? So being able to do that in one system. As a hospitalist physician, the efficiencies that are going to be gained to being able to chart in real time, the communication that will enable with other colleagues in the hospital, consultants. When I think about my hospitalist colleague that's here from a different facility, even the ability to communicate, right, from facility to facility, that doesn't exist today. Right now I'm doing that over the phone, right, paging, waiting, doing it over the phone, fax machines, whereas this will enable us, it will enable that sort of communication, that bi-directional communication, because we're looking at the same information. And even if we're not doing that at the same time, I can log on. If I have a patient and they are seen by a gastroenterologist, for example, I can, through OPOR, see in real time what that physician is recommending, the plan of care, any adjustments to the patient's care, instead of waiting to see the paper record, which I'm not going to get in real time.
Okay, are there any final questions?
Yes, I'm just wondering, what is it going to look like for example, in a hospital? Like, will the doctors have to go to a physical computer, or will they have like an easier access? Because we're everything is to make it easier, faster, but if they have to move to computers, that might go against that. So I'm just wondering if we know what that's going to look like.
You go ahead.
That's one of the most exciting parts for me. When we think about all the time that we waste, like you can walk, if you're ever on an inpatient unit, you can see even the physical space that's taken up by paper charts. Our medical records, rooms, we have full rooms, full. Like these are places where we actually could be providing patient care. So there are several different devices. It might be a phone, it might be an iPad, it might be a workstation on wheels, which is, a computer on a system. It might have a dispensing cabinet for certain common medications. We saw that in Vancouver and how quickly that was to access. And that moves with you as a clinician. So instead of me having to go to a paper chart, that health record is moving with me throughout the hospital system.
Okay, thank you very much.